Move on to the last speaker in our session, Dr. Sperling, who is a maternal-fetal medicine physician here at Stanford and is also affiliated with El Camino Hospital. She has developed both research and clinical expertise in diabetes and pregnancy. And today she's going to talk to us about her RCT.
All right, so let me just start sharing my screen. Can we all see okay?
Yeah, it's presented.
Great. Okay, let me swap. Is that better?
Perfect.
Thanks, guys. So I am very pleased to discuss with you guys today my thesis and fellowship, which was called Fasting Compared with Fed and Oral Intake Before the 1-Hour Oral Glucose Tolerance Test, a randomized controlled trial. Listed with me are my co-authors who were so supportive during this process, and then also Dr. Blumenfeld, who was my research mentor for this project. Okay. Funding for this project was through the Stanford Diabetes Research Center. We were fortunate enough to be the first obstetric project that this center had ever funded before. And then we were also able to get generous funding from our division as well to help get us going. We were also lucky enough to be published. This article was published in the January Green Journal, and then we were also lucky enough to be picked as an editor's pick for their podcast in the same month as well. So a little background: gestational diabetes, it affects around 400,000 pregnancies every year, around 9% in the US. Major neonatal complications include macrosomia, hypoglycemia, hyperbilirubinemia, and birth trauma. Maternal adverse outcomes include increased risks of preeclampsia, cesarean birth, and then subsequent development of type 2 diabetes later in life, with one study even quoting up to a 70% chance after diagnosis within 22 to 28 years. So why do we treat gestational diabetes? We treat gestational diabetes because we know that therapy improves outcomes. And so this was a multi-center randomized trial that split people into receiving no treatment versus treatment. And treatment included things like dietary advice as well as medication if warranted. And they found that all of those adverse outcomes that we had just spoken about were decreased when you treated gestational diabetes. So how do we screen for gestational diabetes? There are two main methods that are used. The main method that's used in the United States is called the two-step method, and this is a 1-hour oral glucose challenge with a 50-gram glucose load that is meant to be administered without regard to time of day or last meal. And then if you do not pass that test with a cutoff between 130 to 140, depending on the institution, then you're given a 3-hour oral glucose tolerance test. That's a fasting test to confirm the diagnosis. And in 2003, a survey study found that greater than 95% of OBGYNs use the two-step method. And then we actually repeated this survey approximately a couple years ago, and we found that more than 90% of OBGYNs still use this two-step method. So still very widely used. And then the one-step method is the other way that is used to diagnose GDM. That's a fasting 2-hour oral glucose tolerance test with a 75-gram glucose load, which identifies approximately double the amount of people as having gestational diabetes as the two-step method. So what does ACOG recommend? They recommend the two-step method because they feel like there's this Eunice Kennedy Shriver National Institute of Child Health and Human Development Conference on GDM found that there's lack of evidence that the one-step method leads to improved maternal or neonatal outcomes, but it causes a significant increase in healthcare costs because of a larger number of people who end up getting diagnosed with GDM. A 2015 Cochrane review found that there was no specific screening method that's been shown to be optimal. So what do we know about fasting or eating prior to the 1-hour glucola? So this is a 1986 crossover study that was developed by Kustan, who put 50 people who were presumed normal subjects and then 50 people who were known to have gestational diabetes. He had them fast, do the 1-hour glucola, and then at another time had them eat a meal and then do the 1-hour glucola. He found there was no difference between people who fasted and people who ate when they were presumed normal subjects. But in those who were known to have gestational diabetes, those who fasted had significantly higher mean glucose values than those who ate prior to their glucola. And then this was a more recent study in 2018, where patients were asked at the time of their glucola how many hours it had been how many hours before they had last ate or drank anything prior to the glucola. And then they kind of plotted everything along a continuous line and found that at 6.5 hours was the cut point that made a difference. And they basically found that those who fasted for more than 6.5 hours had a higher average glucose value, had more people who also would have a value greater than 140 compared to those who fasted for less than 6.5 hours. So why did we decide to do this study? Because we know that more than 90% of providers use the two-step method to diagnose gestational diabetes. It's one of the most commonly ordered tests in pregnancy. Providers have varied perceptions regarding how oral intake will affect the 1 hour glucola. We were finding that anecdotally, people were saying like, we recommend they have a fast or not eat at least a couple hours prior to the test. And then previous evidence did suggest that oral intake made a difference on test results. So our primary objective was to determine the effect of fasting versus eating prior to the 1 hour glucola on screen positive results. Secondarily, we wanted to look at maternal and neonatal outcomes in the fasting versus the fed state, analyze differences in GDM diagnosis based on fasting or fed state, and then assess also patients' perceptions on oral intake prior to the glucola. Our hypothesis was that administering the glucola after fasting for more than 6 hours would cause more patients to screen positive compared to patients who ate within 2 hours of the test. This was a single center prospective randomized trial. We were approved by our Stanford IRB and registered at clinicaltrials.gov. We compared the screen positive rates for gestational diabetes after fasting for 6 or more hours versus eating within 2 hours of the test after a 50-gram glucose load. And if patients screened positive but had a value less than 180, they were administered the 3 hour glucola to determine to see if they met criteria for diagnosis. If they had a value that was greater than 180, they were presumed to have gestational diabetes and were treated as such in our clinic. These were inclusion criteria with singleton gestation. They had to be followed through our clinic, deliver in our unit. We included English and Spanish speakers, and they had to be 18 years or older. We excluded patients who had pre-gestational diabetes or diabetes diagnosed in the first trimester, those who'd used diabetes medication like metformin or glyburide prior to pregnancy, if you had a history of bariatric surgery, chronic oral steroid use, or had betamethasone or dexamethasone within 7 days of the 1 hour glucola. We had 2 groups. We had a fasting group, and then we had a fed group. We recruited through our Stanford outpatient clinic, and patients had indicated an interest in research at their intake visit, and so those are the patients that we approached. We randomized in a 1-to-1 ratio in blocks of 4. Patients were then stratified by low and high risk for GDM. Patients that were considered to be high risk were those who had an early 1 hour glucola, who their provider ordered them an early 1 hour glucola, and for which they passed and were now coming back for their normally timed glucola. And then so each patient got a unique study code, and then they got $15 gift card for participation. Sorry, I'm talking fast. I'm trying to get through as fast for time. For our power calculation, to detect a difference of at least 20 percentage points in the percent screen positive between the fasting and fed groups, we calculated that the study would require 88 patients per group. So we were trying to say 45% in the fasting group and 25% in the fed group we thought would screen positive. And then assuming a two-sided alpha of 0.05 and a power of 0.8, and then accounting for what we thought would be like about a 10% attrition rate after enrollment, we increased our sample size to 100 for each group. This was an intention to treat analysis. Our primary outcome was assessed using Fisher's exact test, and Mann-Whitney-Wilcoxon test was used for continuous outcomes. There were no interim analyses that were performed. We used a secure web-based software for data collection. We looked at maternal data until 6 weeks postpartum and neonatal data until 28 days of life. This is a flow sheet of our enrollment. We were able to enroll between November of 2020 to end of April of 2021. We approached 420 patients who expressed interest in research. Most people just declined participation after talking to them about the study, and those who were excluded. We were able to randomize 100 into each group. We had 97 in the fasting and 98 in the fed group who were included in our primary analysis. And then for our secondary analyses, 96 in each group were included. There was no difference in maternal demographic data. They were pretty similar in things like their age, pre-pregnancy, BMI, race and ethnicity, insurance type, et cetera. And then in terms of our primary outcome, we found that fasting did increase the risk of a positive screen. So in the fasting group, 32% ended up screening positive versus 13.3% in the fed group and a p-value of 0.002. In regards to the mean glucose values, it was 127.7 in the fasting group versus 113.3 in the fed group. With a p-value of 0.03. There were also more people who were diagnosed who did not have to do a 3-hour and were just diagnosed based on a 180 glucola result. It was 8%, like 8% in the fasting group and 2% in the fed group. In the fasting group, it was 10.7 hours was the mean time of last oral intake versus 1.4 hours in the fed group. And then the DDM diagnosis, we had 12.4% diagnosed in the fasting group versus 5.1% in the fed group, but it did not reach significance with a p-value of 0.08. We looked at maternal outcomes. There was no difference that we found in maternal outcomes between the two groups. We looked at different neonatal outcomes, and we also did not find any significant differences in between these two groups as well. And so what did patients think about oral intake and the glucose tolerance test? So after every patient finished their glucola, they were sent an electronic survey from us that would ask things like, how long has it been since you last ate or drank prior to the test? What was the last thing that you ate? And then we asked them, if you had a choice to fast or eat, what would you choose? How do you think fasting will affect the glucose testing results? Just to get a little bit more information on their perception regarding the test. And what we found is that patients vary in their perceptions regarding oral intake and its effect on the 1-hour glucola. Almost 50% of patients thought it would fasting would decrease glucose levels. 20% thought it would increase glucose levels. And then like a little over 30% thought it would make no difference at all. And then we asked patients if they had a prior pregnancy, were they told advice by their provider about how to prepare for the test? And those who said yes, there were 3 patients who said that their provider told them to limit their carbs before. They were told not to eat for 1 or 2 hours before. 7 people were told to fast prior to the test in their last pregnancy. And then 3 said they were given a recommendation, but they didn't remember what it was. So the strengths of our study is that this was a prospective randomized trial. There was very high adherence to each group's arm. We know that approximately 90% of OBs in the US use 1 hour as their screening modality. So we're able to gain further clarity on one of the most frequent laboratory tests ordered in pregnancy. It's a pragmatic trial, and we used post-test survey to assist in ensuring compliance. Its limitations is that this is a single site study, so it may not be applicable to other places. There's a possibility for recall bias on the post-survey, but I will say that over 75% of patients completed the survey within 24 hours, and about 90% completed it within 7 days. It was not powered to detect a final GDM diagnosis by fasting or fed state. Some areas of future research would be to create a larger RCT that's powered to look at the GDM diagnosis. We were almost there, I think, as well as maternal and neonatal outcomes, analyzing different cutoffs in the fasting versus the fed state, using that, because we use 140 at our institution, but some other places use 130 or 135. And then looking at fasting time and carb consumption prior to the 3-hour OGTT and the risk of GDM diagnosis, I think would be very interesting. So in conclusion, fasting for 6 or more hours more than doubled the incidence of a positive 1-hour screen for GDM when compared with eating within 2 hours of the test. And there were no significant differences in maternal or neonatal outcomes based on the fasting or the fed state. And then we just want to say thank you to our patients and our research team. That's it. Thank you.
Thank you, Dr. Sperling, and congrats for finishing this very pragmatic RCT in your fellowship.
Thank you.
We might have time for just one question if there's anyone who wants to jump on. I don't see any in the chat. If not, I can ask a quick question. How did you assess adherence to your intervention?
We assessed adherence based on the survey. So we would ask them how long it had been since they last ate or drank anything. And so from there, we would be able to say if they're in the fasting or the fed group, if it met within that time frame.
Makes sense. Awesome. There's some kudos in the chat. So congrats on this great work.